Nau mai, haere mai, piki mai, kaki mai, kia ora iwi, and welcome to 30 with me, Guyon Espiner. 30 minutes, one guest, no cuts. What we record is what you get. ADHD, 4 letters on everyone's lips right now. Diagnosis and prescriptions for attention deficit hyperactivity disorder are rocketing, especially in the rich world. Between 2006 and 2022, prescriptions for ADHD medications increased tenfold in New Zealand. Pharma says demand for ADHD meds has increased 140% here in just the last 2 years. Psychiatrist Dr. Sam McBride is concerned that we are over-diagnosing and over-medicating, especially for people who don't have severe symptoms. Sam McBride is the New Zealand representative on the Faculty of Addiction Psychiatry at the Royal Australian and New Zealand College of Psychiatrists. He warns that stimulants prescribed for ADHD are aggressively marketed by drug companies who can downplay the harms. So what are the dangers of our current approach to ADHD? Let's start the clock. 30 minutes with Sam McBride. Sam McBride, welcome to 30.
Thank you.
Thank you very much for coming into the studio. We really appreciate your time. What is ADHD and how is it diagnosed?
Look, it's so to some extent it's on a spectrum of normal. So it's a disorder of attention. So difficulties with memory, difficulties with sustaining attention to tasks, forgetting things. And then it's a deficit of hyperactivity. And impulsivity. So, we typically often think of it as in children, always on the go, not able to sit still, running around, saying things when, you shouldn't, blurting things out in class. So it's a cluster of symptoms, but none of them are unusual in of themselves. So it sits at the extreme of normal experience.
And so are these things that we would all normally experience anyway to some degree, but then people with ADHD have extreme sort of manifestations of those?
That's right. It's a cluster of symptoms that by definition, need to be a disorder and need to be associated with impairment. And it's important not to downplay ADHD and the impact that it can have. So it's associated with high rates of imprisonment, it's associated with impaired academic performance, it's associated with, kind of impaired social relationships. And because of that, people can, feel bad about themselves and experience other associated, problems.
And you would have seen those people, would you, in your work?
Yes. Well, I work in an addiction service, so they're highly represented within addiction services, and so I diagnose and treat ADHD within our service, and it can be highly rewarding, when you get it right.
And it can be a big impairment. It's a serious condition when you have a severe case of it.
Yes. It's probably associated with significant morbidity, increased mortality through kind of a range of reasons, higher rate of accidents, and as I've said, a kind of a range of kind of social difficulties, difficulties in relationship, difficulties at school. As I said, people can be more likely, there's probably an overrepresentation of ADHD within our corrections facilities. It's also associated with impaired physical health conditions as well. So it's not a benign disorder in of itself.
Is there a biomarker? Like, are there any actual biomarkers that determine whether you've got ADHD?
No, and that's that's not unusual across a range of psychiatric conditions certainly, but also physical conditions as well. There are associations. So if we look at EEGs, we commonly see changes. So EEGs, brain scans, that can be associated with changes. There's some radiological or evidence from scanning that is suggestive of biological processes as well. but they largely sit in the research field. None of them are used clinically, and none of them are diagnostic in of themselves.
So how do we diagnose? Because many of us might have done those tests. I went on the website, the ADHD New Zealand website, with questions like, how often do you have problems remembering appointments and obligations? Well, quite a bit. How often do you misplace or have difficulty finding things at home or work? Or how often do you feel restless or fidgety? You know, these were behaviours that I recognised in myself. I'm just wondering how you diagnose it, and is that diagnosis consistent, do you think?
Oh, yeah, it's a good question. So diagnosis, you know, probably in the first instance, it takes time. So it's not a, you know, it's not a snapshot, and it shouldn't be a single interview or interaction. I guess when I started training, you know, my first exposure to ADHD was in child and adolescence. So we would, you know, receive a referral from a general practitioner. Usually, it would describe a history. We would meet with a child. We would meet with their family, and we would take a history. We would obviously look at symptoms, you know, that are consistent with ADHD, but we'd also look for comorbidities or other things that might be going on that could be associated with those things as well. So it might be depression, it might be anxiety, it might be societal, you know, kind of social stresses or family stresses that could replicate it. We'd go and do visits in school and observe them at schools. So we'd get collateral information from a range of people. You know, sometimes we might even ask, you know, psychologists to see the child as well and do neuropsychological tests. So in short, there's a diagnostic interview. You'd get collateral information. You might use some screening tests. And you would exclude other factors that might be, you know, kind of causing or associated with a symptom.
So this takes time. It's not a quick test.
Yeah.
Is that happening now, though, or do you believe that people are doing very, very quick diagnosis of this condition?
Yeah. Well, yes, that is one of my concerns. Or people are using simplistic assessments. And so you mentioned screening tests, and you know, screening tests in of themselves aren't worth much. I actually, you know, personally don't think they should be available on, you know, kind of public domain to some extent, because they require some recognition of the limitations of those tests in the context. So those tests, what they don't do is they don't contextualise the symptoms that person has, you know, in the environment that they're within or what else might be going on. Those tests are particularly designed to reduce the rate of false negatives. So essentially, they're a broad screen which aims to, you know, kind of capture as many people as they can. They have a risk of reinforcing, you know, kind of the diagnosis in people's mind. You know, so we all have a cognitive bias. We look out for you know, kind of what we believe, and when we're kind of primed with this information, we're often more likely to, you know, to kind of see it in ourselves.
So do you believe we are over-diagnosing ADHD?
Oh, I think there is, yes, I think we're over-prescribing, and there is a risk of over-diagnosing ADHD. And I think we need to be cautious when we look at international trends around ADHD, what's happened in other countries. So if we accept a sort of a broad prevalence, and you know, there's debates about what it is, but of, say, 5% of ADHD in children and 2.5% of ADHD in adults, you know, there's significant variance across countries. You know, if we look in America or the USA, you know, up to 10% of children have been diagnosed with ADHD, which suggests that there's a real potential for overdiagnosis. And I am concerned that we might, you know, we might be moving into that territory in New Zealand. And I'm concerned that we're simplifying complex problems. We might be, you know, kind of missing other conditions that could be associated with symptoms of inattention, and we're not talking about environmental factors that might be associated with it as well.
So how widespread is this concern among your profession?
Oh, look, you know, like in any field, it's you know, there's a range of views. I was reassured when sort of preparing for this interview and sort of talking to peers, you know, not just people I know and like, but, you know, I was talking to child and adolescent psychiatrists and other psychiatrists, and there is a lot of concern out there, and it's shared, and it's shared, you know, also by other health professionals such as you know, kind of GPs. It's concerned by psychologists, clinical psychologists that I work with who have a, you know, kind of obvious interest in this. It's also concerned, I think, by, you know, kind of other members of the community, teachers and others who are seeing this.
So what are we doing here? Are we pathologising normal behaviour?
Oh, we would run the risk of pathologising normal behaviour, and again, it's important not to be, you know, kind of too polarised about this. You know, ADHD is a real condition. As I've said, it's associated with real impairment, and medications and other treatments can make a significant difference. But yes, we run the risk of kind of pathologising what actually a normal experience is. And
why do you think that this is happening? What are the factors behind it?
Oh, look, there's, you know, it's complicated, and you know, there's no one factor. You know, I think we can look at you know, within the medical profession, there's been changes to the way in which we diagnose and identify ADHD, and so I think that they have loosened over time. I think there's a significant.
So just to stop you there, so what? We have lowered the threshold of the sort of symptoms or the severity of them before we would make that diagnosis. Is that what you mean?
Yes. So you know, I guess one of the commonly used diagnostic instruments that we use in psychiatry is a DSM, and it sort of goes through iterations as people research and learn more. One of the things that has happened with the DSM-5, which is our current.
Yeah, so that's the the Diagnostic and Statistical Manual of Mental Disorders, and we're up to DSM-5 because this is run by the American Psychiatry Association, right? So they put this together. That's the Bible, right? The mental health Bible, if you like.
It's one of the diagnostic tools we use. Yeah.
And that is subject to change, isn't it? Because between the DSM-4 and the DSM-5, they completely wiped out Asperger's as a specific condition. There were 37 million people worldwide who thought they had Asperger's. That was collapsed into autism spectrum disorder. So these things change, don't they?
Yeah.
And do they, to some degree, change with the cultural or the narrative and the momentum of how we perceive these conditions?
Yes, well, again, you know, so again, important not to be too black and white with it. You know, the DSM is a useful tool. It allows us to, you know, kind of be reasonably consistent, and, you know, or at least aims to achieve consistency. It allows to think and plan and prepare treatments that are appropriate for, and it provides a research base as well. Nor is it, you know, medicine is constantly changing and evolving as we research, we find more things. I think psychiatry in particular is probably vulnerable to, you know, what we call kind of concept creep. And the DSM-5 has been criticised for the way in which it potentially is expanding the boundaries of diagnoses and capturing conditions that might not in themselves represent severe disorders.
So when you say concept creep, this is, you know, using words like depression and trauma, but not in their scientific or very prescribed way, but broadening that out to describing someone who's sad as depressed. That sort of thing. Yeah. And certainly, you know, there's been a lot of discussion about this, and I think it is something that, you know, certainly we see clinically. And so, you know, as you've said, anxiety in of itself is a normal experience. It's a really useful experience. It prepares us for you know, what's potential threats or something we need to get ready for, like exams. But anxiety isn't an anxiety disorder, which is, as you say, prescribed, associated with significant impairment. Likewise, we all get sad and unhappy for a range of reasons, but we need to be careful about distinguishing that from depression. Do we have an element of social contagion here then? In other words, are people going out, they're seeing that others have had this experience with being diagnosed with the ADHD, that they're forming some identity around that. A lot of the people find that's a very positive thing for them. They're going out on social media and other platforms and talking about it, and other people are then looking for that same sort of experience. Is that partly what's driving it?
Well, I wouldn't cause it contagion. You know, I think there's a range of drivers, you know, kind of for it, and so we've talked about some of the big picture stuff in terms of, you know, changes to the DSM, you know, 5. I mean, I think one of the things that we've seen And again, it's not a bad thing, but we've seen advocacy groups in terms of wanting to promote, create awareness of ADHD and ensure that people have options of treatment. I think there is an element of looking to others, and so as parents, for example, if we see our child struggling or is inattentive, then we want the best for them. And I think we've got to be aware also of the role of pharmaceutical industries in terms of driving this narrative. And then finally, not separate from those things, I think we need to be aware of social media and the way in which this reinforces narratives and the role of algorithms in terms of reinforcing these things as well. So I don't think there's one thing. There's a whole range of factors that we need to be aware of. And again, it's not about discounting ADHD. It's just about being aware of the context in which we're talking about it and as doctors diagnosing, prescribing for it.
Let's talk a little bit about the medicines that are prescribed for ADHD. I mean, these are stimulants, are forms of amphetamines, are they, or speed-type drugs?
Oh, they're associated with classes amphetamines as well. So I mean, there are a range of medications. So the most commonly ones that we use are stimulant medications, and you're right. They come from the class of amphetamines. They have, kind of largely the same impacts in terms of neurochemistry. They increase rates of dopamine, which is a neurotransmitter, and noradrenaline in the same way that kind of amphetamines do, but they're significantly less potent. And sort of prescribed doses would be far less than people might use for, if misusing methamphetamine.
Do you see though diversion? Like, are people getting these drugs to use or to give to other people to use recreationally, do you think?
Oh yes, I mean, So I mean, one of the things we don't have in New Zealand is particularly good awareness of what is happening in our community with these medications and whether they're being diverted. I'm not aware of any kind of good local research on that. Anecdotally, yes, and certainly within the service that I work in, yes, definitely. Also, if we look at international literature, and most of this is coming out of the US. It seems to be particularly associated with college-age students at university, I guess, in this respect, then who have high rates of prescriptions for ADHD, then to some extent diversion, the giving or the selling of a medication to others is the norm as opposed to the exception. So I think it is common, and I was kind of looking at some research recently which said 0.6% of Americans are using non-prescribed stimulant medications.
And what are the risks or side effects of these drugs just for people who are prescribed them for ADHD? I mean, do they have side effects that people need to be aware of?
Yeah. I mean, again, important not to be too polarised. All medications have side effects. All medications are, kind of a balance of kind of risk and benefit. So there might be, common, kind of short side effects associated with use, so they can make people restless, particularly in children. They may often make them anxious. They can be associated with gastrointestinal upset. They can suppress people's appetites, and so it's been shown that children who've, kind of used stimulant medications for a period of time have slightly, are slightly shorter. So there's those sorts of side effects. There are, what we don't have is particularly very good long-term evidence of what side effects might be. So most of the studies that we have are just over the short term. But there's concern about cardiovascular side effects because of the nature of these medications. The stimulant medication, they increased heart rate and blood pressure. And they've been associated with increased hypertension and vascular disease. There's concern, and you don't want to overplay this, but there's concern that long-term exposure may increase risk of neurological conditions such as Parkinson's disorder. And then I worry about the risks of diversion and non-medical use as well.
You touched on this, but do you think that the pharmaceutical industry is playing a part in stoking all this along?
Oh, again, sorry, I sound like I'm an echo chamber, but let's not be too black and white about it. So pharmaceutical companies, on one hand, are great. They research and develop medications, that we really need for our health and well-being. But they're also businesses. I take a medication for blood pressure. Pharmaceutical companies aren't interested in me as a consumer of that and my blood pressure. What they are interested in me is as a consumer, and so the constant drive for pharmaceutical companies is to develop market share, to grow their market, and so they'll act like any other business and look to expand their market share, and it's very clear over time that this has been happening with all medications, including ADHD medications.
Yeah, they're fairly involved in the sort of amongst the specialists too, aren't they? I saw that Takeda and Novartis, which make some of these ADHD meds, sponsor the Australasian ADHD Professionals Association conference. I mean, I guess that's what you'd see, but is that a healthy relationship, do you think?
Oh, look, I think we need to be really cautious about our relationship with pharmaceutical companies. It's clearly shown through research, that even that by engaging with pharmaceutical companies, our practice changes and we'll be more likely to prescribe the medications that they have. New Zealand, in many respects, I think is kind of much better in this regard than other countries. The College Psychiatrists, conference we held here recently, for example, didn't have pharmaceutical company sponsorship for that very reason. And I think it has, certainly the culture has changed, while I've been in medicine. But it's it's a dynamic we need to be really, really cautious and careful about.
You talked about social media before too. I mean, is there a link up here? I mean, are pharmaceutical companies using social media websites to promulgate this?
Yeah. I mean, so what they're certainly doing is that they have websites provided to, or developed to provide information on ADHD that they sort of sponsor. So that's really obvious. And when I've looked at some of those, I would argue that they're essentially predatory in terms of how they promote ADHD. So we know that. In terms of wider social media, I guess we don't, we don't really know because it's not visible, or obviously visible. But I found it interesting or instructive to look at the, kind of pharmaceutical marketing literature, and what that's really clear about is, is using social media to drive a narrative around, kind of medications and diagnoses. And the language I found interesting. So it was about, informing the consumer, but what, educating the consumer, which in itself is kind of great, to be educated. But you're being educated with the pharmaceuticals, industries, kind of information and what they want you to know, rather than a balanced narrative. I think there's a kind of a broader concern about social media, kind of platforms such as TikTok, and that ADHD, is really highly represented. But when people have studied this and looked at the information that is provided, it's really inaccurate.
So if someone presents with mild symptoms of ADHD, would they need medication? Yeah,
so I mean, I think some medication can be, is really useful. As I said, I kind of prescribe medication, and I've seen huge benefits in people I've treated it for. But we also need to be realistic about the benefits of medication. Actually, if we look at the evidence for use of medications, and it's predominantly short term. The evidence is often poor. It's often been, sort of influenced by pharmaceutical companies, or there's, kind of research flaws in terms of how it's developed. And the most robust, kind of evidence is that actually, the gains from medication are limited. That they don't necessarily seem to be sustained over long periods of time. Yes, so there's limits to it.
So those people might not benefit that much at all from medication?
Yes, so I think we need to be more, careful about how, who we're treating, And so I think people at the severe end of severe ADHD are the ones who should be prioritised, and the people who are most likely to benefit, and where benefits are more likely to outweigh risks. But we should be cautious about having a one-size fits all approach. One of my concerns about the narrative at the moment is it's largely medications that we're promoting as interventions. What we're not hearing about is psychological therapies, for example, or environmental strategies that people could implement. And I think the benefits of medication are greatest in people with a severe disorder, but are less likely to be useful for people with kind of mild to moderate ADHD. The other thing I think of is that we tend to overestimate the kind of benefits of medication. So we mistake subjective improvement, this medication makes me feel better, versus functional change over time.
So when you talk about environmental factors, are you talking about things like scrolling on phones all the time, or having a lack of exercise or high pressure, or those types of things? I mean, can they contribute to these sort of issues?
Yeah, well, there's a whole range of kind of factors that might be give us symptoms of inattention or kind of hyperactivity, and so so in terms of environmental factors, so as you've said, sleep can impact on that. Substance use, kind of often is, whether that's excess alcohol or in excess caffeine, kind of might be associated with symptoms of inattention or hyperactivity. I think there's a question about, one of the questions is, that has been is our attention span changing? Now I don't know if we can tell that from looking at evidence or literature, but it's really clear that our environment is changing, and our environment is changing in a way that will impact on our attention. And certainly there's associations of kind of use of social media, high use of social media, or even high use of screen time, and that impacting on attention.
So you're worried that people are going to be living in this world that we are living in now, and increasingly going and seeking an ADHD diagnosis, getting it, and getting medication that they don't need. Is that your worry?
Yes, so I'm concerned that we are simplifying a complex diagnosis. We're simplifying treatments for that diagnosis, and yes, that we run the risk of sort of over-medicating, a much more complex problem.
And what are the impacts of that? I mean, you touched on some of that possibly you crowd out those who actually do really need help and have had more severe symptoms. Because there's only so many of you guys to go around, right? I mean, we don't have an excess of psychiatrists in New Zealand, do we?
Yeah. Well, I think that's a really important, kind of a really important point. That there's been a lot of discussion about ADHD and people not being able to access treatments for ADHD. But I'd argue actually, there's a whole lot of, kind of people are not able to access treatments, and I do have a concern about opportunity costs, that the ADHD has dominated the narrative at the expense of kind of a whole range of other mental health conditions that are equally deserving, and the people who are most likely to kind of miss out on kind of mental health treatments are those at the severe end, kind of mental illness. And yes, so we run the risk of diverting kind of medical resource and attention away from the severe end of mental illness and mental disorder.
Pharma has funded a new drug for ADHD just in the last couple of days, and they've also announced that they're going to remove this renewal criteria for the stimulants that are given as treatments. This previously you needed to go back every 2 years, I think, to a specialist such as yourself and get this renewal to take these stimulants. But it looks like they're going to do away with that. Are you supportive of that move?
So they've removed Pharmac's special authority, which to some extent is a fiscal constraint. So, Pharmac's intention is to reduce the fiscal cost, So that was there to make sure that people, still required that medication and it was appropriate. I think in many respects, given the nature of things, in some ways removing that is a pragmatic decision at the moment, given the demands are on services. I do worry that we're, Karen.
No, I was just wondering, the other thing on the table is whether GPs should prescribe. What are your thoughts about that?
Oh, yeah. So you know, I think there's a number of issues. One again is you know, what about opportunity? I think in terms of a diagnosis itself, I don't think it's simple. You know, it's actually, you know, I think in some ways it's much easier to give a diagnosis than to not to give a diagnosis. You know, to think more broadly about what might be going on. I worry about what happens with, you know, ADHD is associated with a kind of a range of comorbidities, you know, in terms of mental health. So, you know, kind of anxiety disorders, depressive disorders, and substance use disorders, which take time, you know, kind of an attention, and also need to be thought about when you're planning treatment. And so I worry that we may not, you know, we may simplify that process. I worry a little bit about opportunity cost. So it's not clear to me there's so much capacity within primary care that you know, there's space to do this. And so if we, you know, kind of move prescribing and diagnosis into primary care, what are we not doing? And my worry is that people at the severe end of both mental health or even physical health will miss out on care. So I think it's, you know, that kind of bigger picture we need to look at.
We're just about out of time, but what is your message as to how we should change the way we are approaching this?
Oh, so you know, again, I think it's important to be, you know, kind of not polarised about this. I think, you know, ADHD is a, you know, significant mental disorder and associated with significant comorbidity, but we need to be really aware of the context in which we're prescribing, diagnosing, and talking about it, and take a thoughtful and careful approach to it, and be aware of the risks and opportunity costs of doing so.
Thank you very much for your time and for coming into the studio for 30. That was 30 Minutes with Sam McBride. This is 30 with me, Guyon Espiner, and we'll catch you next time.